Start.
Yes, sir. A very good evening to one and all. I am Arpita, the moderator for today's session from the IGCP group. I welcome you all to another webinar with us on the topic SGLT2 inhibitors as first line therapy. And to address this topic, we have with us someone very eminent from the field of diabetology, Dr. Bansi Sabu sir. Though sir doesn't need any introduction and sir is very known to all of us still, to start with the session, sir has done MD in internal medicine, post that he has done FACE, PhD, RSSDI Chief Diabetologist and Chairman of the Diabetes Care and Home Care Hormone Clinic, DiaCare, Ahmedabad. Sir is Chair-elect IDF Southeast Asia. So, sir, with this very brief introduction of yours, I would now request you to please start with your session. Over to you, sir.
Thank you. Thank you for kind words of introduction. What I am going to talk in next 25 minutes, what medication we should use first. So I'm thanking all the delegates who are joining me on my live YouTube from IJCP and all the delegates and the doctor's friend also. So normally a type 2 diabetic patients, we are always confused what we should use first. It's definitely, we start with as far as guidelines are concerned, still the metformin which we would like to use. But here I'm going to talk that instead of metformin, can we think of using SGLT2 before that? And my answer for this will be the SGLT2 inhibitor. The point is, why we are treating diabetic patients? We are treating diabetic patients to decrease the cardiovascular risk. The diabetic patients are more prone to develop cardiovascular disease. They have otherwise also multiple risk factor even at the time of diagnosis itself. So what are the medication which can decrease cardiovascular risk? It is GLP-1 and SGLT2 inhibitor. The other two drugs had also shown, but in query or gray zone, which is metformin and pioglitazone. While there are medication like sulfonylurea, DPP-4 and insulin, which does not have any effect as far as cardiovascular disease is concerned. So you should use the molecules which are going to help your patients to decrease cardiovascular risk. Now, type 2 diabetic patients, even at the time of diagnosis itself, they have multiple cardiovascular risk factors. They may be smoker, they may be overweight, they have hypertension, dyslipidemia. And that increases the risk of hospitalization for heart failure, CKD, and atherosclerotic complication. That leads to some events like cardiorenal or atherothrombotic. And that leads to a lot of complication like repeated hospitalization for heart failure, progressive renal functional decline, and post-MI. And that leads to death. So even at the time of diagnosis itself, and even after few years of diagnosis, many of our patients are already at the risk of developing heart problem. The common pathophysiology between type 2 diabetes and CVD is insulin resistance, inflammation, it is oxidative stress, hypercoagulability, high blood pressure, dyslipidemia, and obesity. So the risk of subclinical atherosclerotic starts rising in pre-diabetes. Even someone is not even diabetes. I have a data to show. I had shown you a slide which is showing that even at the time of diagnosis of diabetes, they are at the risk of developing heart disease. But we have data to show that even someone at the pre-diabetes status, they also have high risk of coronary artery calcium score, carotid artery getting intima media thickness increasing. Even in iliac and femoral arteries also, it had shown increasing risk of atherosclerosis. So this shows that even a person who is pre-diabetes, their risk is also increased as far as subclinical atherosclerosis is concerned. The markers of subclinical heart failure are also high even at pre-diabetes status. So the person even not having diabetes also having high risk for heart failure too. Heart failure is like a many of our patients who are non-diagnosed. It's a highly prevalent condition, but often undiagnosed complication. Between 25 to 40% of our patients have diabetes have heart failure. They have asymptomatic, they have diastolic dysfunction, they have LV dysfunction, systolic dysfunction. So many of these patients are not diagnosed with heart failure. SGLT2, which actually helps us for this beneficial outcome in heart failure. Their mechanism of action is It increase uptake and decrease consumption of glucose. So that fatty acid increase itself is helping the patients for heart failure. The accumulation of lipid and glucose, which is there in cardiomyocytes, that is also decreased because of SGLT2 inhibitor. There is a impaired autophagy is there, that is also improved by SGLT2 inhibitor. And this restoration of autophagy with the help of SGLT2 inhibitor is really a very beneficial effect for those people who are having subclinical and having established heart failure. So there are multiple cardiovascular benefit with SGLT2 inhibitor in compared to any other first line anti-diabetic agent. So if I just compare with other agents, we have a sufficient data, and that data first time produced by 2013 as an AMPA-REG outcome data, which had shown first time in history that a person with a long standing diabetes, a molecule given decreases all three P MACE in all major adverse cardiovascular events, including death, hospitalization for heart failure and death. And this data you can see in last 10 years produced by different SGLT2 inhibitor. Yes, definitely there are other GLP-1 analog also who are also equally beneficial too. And this consistent pattern is seen across all different SGLT2 inhibitor, whether it is EMPA-REG or whether it is a DAPA heart failure study. All of them had shown a significant benefit across different SGLT2 inhibitor class. Hospitalization for heart failure is decreased. This effect of SGLT2 inhibitor on overall CV death or hospitalization for heart failure or heart failure outcome, you can see overall there is a decrease in 23% first hospitalization, repeated hospitalization, and 15% by CV death. If you see with atherosclerotic cardiovascular disease, this decrease is further high. Even those patients who does not have established cardiovascular disease or atherosclerotic cardiovascular disease, still there is a benefit by decreasing 5% CV death. First hospitalization in these patients also by 37%, which is very, very significant. And that's the reason I'm putting that it should be considered as a first line. If those who have with kidney disease, without kidney disease, still the benefit is there. And those who have established heart failure, without established heart failure, still it is there. So in type 2 diabetic patients, in any condition, from first detection to with any complication, there is a benefit. And that's the reason using SGLT2 inhibitor will give them CV death benefit as well as hospitalization for heart failure. Even you compare with male or female, even someone is elderly or young, both of them get the benefit of it. A person with heart failure outcome and CV death across cardiometabolic disease spectrum, if I do the systemic review, you will find the people with young age, with whatever EGFR and whatever BMI, they get the benefit of this. So the effect of DAPA on worsening heart failure and CV death was consistent across all subgroup in DAPA heart failure study. That is type 2 diabetes versus non-type 2 diabetes, with whatever the background therapy they were having, whatever the baseline LVF, whatever the renal function, less than 60 EGFR, more than 60 EGFR, whether they were on diuretic, not on diuretic, the heart failure etiologies, whether ischemic or non-ischemic, even the blood pressure may be higher or lower, background therapy may have sacubitril or valsartan, may not have, or even anti-proBNP, whether it is higher or decreased. In all quartile, everywhere, the benefit was there by using DAPA. And this is the DAPA heart failure data. DAPA heart failure data had shown that it is not that the beta blocker or ARNI or ACE is a pillar of therapy. It is MRA, and now it is DAPA, which is established as a fourth corner of heart failure therapy, which is a fundamental therapy for heart failure therapy. It is, we all know that SGLT2 inhibitor is completely beta cell independent, and that's how it reduces hyperinsulinemia in type 2 diabetic patient. It's the hyperinsulinemia which is responsible for their heart pumping to get decreased. SGLT2 inhibitor that rapidly clears even on the day second. You will be surprised to know that even on the day second there's a decrease in 25 milligram of fasting sugar. The C peptide increase, there is a beta cell function improve, and beta cell glucose sensitivity also improve, even with a single tablet with the second and third day dose also. SGLT2 inhibitor improves time in range from day 1. So you can see in baseline type 1, day 128, from day 1 there is an increase in time in range. You are seeing average patient with 50 to 55 On the second day, you will see there as after giving them SGLT2 inhibitor, the time in range improves, and within 28 days, it had shown almost most of the patients are now achieving more than 75% of the time in range 2. DAPA or SGLT2 inhibitor, it improves the insulin sensitivity. It helps insulin resistance to get lost, and it promises in a different beyond diabetes status. There are multiple other benefits also by decreasing the inflammation, increasing adiponectin, and very important is it increases fat browning also. SGLT2 inhibitor also improves hypothalamic insulin sensitivity, that is central action of this SGLT2 inhibitor even at hypothalamic insulin sensitivity. SGLT2 inhibitor improves insulin sensitivity in people with type 2 diabetes who have very high insulin resistance. And that has been shown by decrease in HOMA-IR, fasting insulin is decreased, and remnant like cholesterol is also decreased with that. SGLT2 inhibitor may reduce liver fat synthesis, and that's how it helps in patient with MASLD. It helps in patient to reduce their liver fat synthesis as well as accumulation, and that's the benefit of putting the SGLT2. SGLT2 inhibitor modulates NLRP3, a inflammasome activity via ketones and insulin in diabetes with cardiovascular disease, and that's very very important. The patients are CV death benefit is there with this drug. The cardiorenal benefit, it's not only the cardiac benefit, it is the renal benefit of SGLT2 inhibitor that is also beyond glycemic control, and that benefit we have recently EMPA kidney failure data also, and other molecules which are coming with DAPA kidney, it had shown the benefits are beyond glycemic control. The extra glycemic effect is not only on heart and kidney, they decrease blood pressure, they decrease body weight, they improve lipid profile, they help us to calorie restriction for the patients, adaptive ketogenesis, positive effect on arterial stiffness, and improve endothelial dysfunction. So in rough, they are going to reduce the cardiac workload, and that is because of osmotic diuresis of SGLT2 inhibitor. This is one more paper that SGLT2 inhibitor use demonstrate lower risk of end-stage kidney disease, CV death, hospitalization for heart failure, ACM, similar risk of MI and stroke versus GLP use in type 2 diabetes. This is the empirics data, which they try to show that people who are put on SGLT2 inhibitor, in compared to that, the molecule like Jardians, which is had shown empagliflozin to shown that there is a decrease in CV death, end-stage kidney disease, CV death, all-cause mortality or MI after the EMPA outcome data and EMPRISE. This legacy effect of hyperglycemia and early use of SGLT2 inhibitor has shown so much so benefit that early introduction of SGLT2 in 0 to 1 year and 0 to 2 years. So suppose you are giving them in early course before 1 year of diagnosis, and suppose someone you give the after the diagnosis, maybe in 2 years, there is a difference between glycemic control and CVD also. The holistic therapeutic approach is to optimize the efficacy and minimize the side effects of the treatment. The ideal component of the holistic therapeutic approach is to have a good glucose control, which is safe and going to give a good glucodynamics to the patient for a holistic approach for diabetes management. SGLT2 inhibitor should be considered as a first add to comprehensively address vasculometabolic risk in people with newly diagnosed, which is for adiposity, which is most important thing, that is with the chest and leg. It also help in the failing myocardium because it will help us to reduce the cardiac mortality. It will decrease the chances of getting heart failure as well as death. It also have benefit at ischemic CV disease. Renal and retinal dysfunction is also improved, and systolic blood pressure and sensitive blood pressure also decreased with the using first add as an SGLT2 inhibitor. This is the American Diabetic Association in 2024. They had come out with a SGLT2 inhibitor with a proven benefit of heart failure in this population, and they should use it. This is what they are requesting and asking for us. In conclusion, SGLT2 inhibitor have revolutionized the way type 2 diabetes is treated today. For decades, good glycemic control was the only way to reduce CV and renal risk. In diabetes patient with SGLT2, it is possible to target cardiorenal metabolic risk independent of HbA1c target. Multiple comorbidities associated with type 2 diabetes can be targeted with a single drug. And which are they? Obesity, NAFLD, hypertension, CVD, and renal disease. All these can be given with a single molecule, which is SGLT2 inhibitor. SGLT2 inhibitor have impacted type 2 diabetes, heart failure, and CKD guideline across the globe. to define a new standards of care. With this, I thank once again IGCP and all the delegates who joined us, and I'll be very happy if you have any questions. Thank you.
Thank you,
Yes,
sir.
Vida.
Thank you so much, sir, for your presentation. Now, shall we go ahead with the questions?
Yes.
Right, sir. Sir, the first question is, how do you foresee SGLT2 inhibitors being integrated into clinical practice as a first-line therapy, and
I think
particularly,
in near future, almost most of us are started using it. But even somebody is using metformin, it will be always a dual with first line as a SGLT2 as a added on metformin. So that will what I am seeing, because most of the diabetic patients have already multiple cardiovascular risk factor. So primarily you are treating diabetic patients to prevent them from a cardiac and kidney problem, and this is the answer.
right, sir? But, sir, particularly in cases where the resource-limited settings are there about cost
But
and
even they are
accessibility.
not very costly. After it had become off patent, most of the SGLT2 inhibitor are costing less than 10 rupees. Some of them at a generic brand are costing even less than 5 also.
Right, right, sir. We have received a question, sir. SGLT2 dose in CKD with CRCL less than 30 and CKD.
We had used it up to 20 EGFR. It can be started up to 30 also before that. But normally when someone is below the GFR 30, you may or may not start also. Because the benefit of glycemic control will not be great.
Right, sir. Right, sir. Uh, Moving on to the next question, sir. What are the key factors to consider when selecting patients for SGLT2 as a first-line therapy, in particular in patient with early diabetes or those without established CVD?
One is definitely your C peptide level. If it is high, then you can start. The other is, your uh, someone who is already taking it. So they are important also to understand that is there any side effect. But the key factor is you may have a multiple risk factor. So we do now ASCVD risk score for the patient. But definitely you check their ASCVD risk score, cholesterol level, hypertension, sedentary lifestyle, smoking habit. All those are very important point. If you find that multiple risk factors are there, it's better to start the patient.
Right, sir. Sir, how should clinicians address concern about potential side effect of SGLT2 inhibitors,
So one
such as
biggest is a genito-mycotic infection.
right,
And for
right, sir.
that, I mean, how you teach, how you educate, how patient keeps a good hygiene, all those things will definitely help. But yes, definitely it's a major challenge for many of our patients.
Right, sir. And sir, do you anticipate upcoming diabetes management guidelines will universally endorse SGLT2 inhibitors as a first-line therapy?
Yes, most of the guidelines will say it already. American College of ESC, European Society of Cardiology, had already put it, and from 2019, other guideline had already put it that it should be as a first choice along with metformin. But a time may come that it will be considered the first line.
Right, sir. Thank you so much. There are more questions coming on. So, among DAPA, CANA, and IMPA, which is best?
So at present we are using DAPA because it's a off-patent DAPA heart failure, but EMPA is also done, so you can use any of them.
Right, right, sir. So there are also compliments coming in. Excellent presentation, nice presentation. Thank you so much, all. Let me see what are the other questions. We'll take two or three more questions and then we'll conclude the session. So
Thank
please
you.
start in the questions. Sir, how do you recommend initiating SGLT2 inhibitors as a part of combination therapy right from the diagnosis?
I write for many of my patients when SBNC more than 8. So instead of putting them only on metformin, we try to put it with that patient because ultimately it is going to give you a lot of benefits of decreasing cardiovascular mortality.
Right, sir. And in cases of special population like elderly patient or patients with
So
fatality,
elderly is a concern. That's what we educate them, but young patients definitely we do it.
right? And so in cases of hepatic function impairment, what do you
It can be
suggest?
used and it should be used with the patient with liver cirrhosis. Also, it has been shown in useful.
Okay, okay. Very nice. Sir, do SGLT2 inhibitors complement lifestyle interventions like diet and exercise? Are there any
Diet and
risks?
exercise are utmost important. One cannot undermine the importance of diet and exercise. It is the only way by which you can even reverse your diabetes also. So think of diet and exercise should be as a part of prescription. We write it as a separate prescription. We teach, we educate, we have educator, we have dietitian, we have a social worker, counselor, and then ultimately we try to explain the patient that diet and exercise is much more important. Definitely, medicine also sometimes.
Sir, can oral semaglutide be used for obesity patients without diabetes? Is it recommended?
Yes, it can be, but still the dose is very less because we are doing a dedicated trial of semaglutide, which will be used in obesity patient between 16 and 25.
Right, right, sir. Audiences, let us know if there are any more questions, or else we will be wrapping up with the session. So we'll wait for another 1 minute. Let us see if there are any more questions, or we shall conclude it for today. Thank you all for putting up your questions. Let me know if there are any questions. We'll wait for 1 minute more. I think, sir, there are no more queries from our audience. So we
Thank
are
you.
writing. Thank you so much, sir. Thank you all. So with that, sir, I would like to thank you for taking out your time and giving us a valuable presentation. Thank you so much, sir. Thank
Thank
you all
you.
for. Thank you all.